Hello, I'm George. I'm from the respiratory department. I'm going to go over mechanical ventilation for you. Mechanical ventilation is generally seen in three separate but conjunctive parts. The ventilator itself, this is a servo eye, what's commonly used here throughout the hospital. The circuit, which is usually two distinct tubings, one going to the patient and one returning to the ventilator, and three, the patient themselves, which is the discussion that takes into consideration the airway that you see that's in place here. This is a cuffed endotracheal tube, will be placed either by anesthesia or perhaps by the respiratory staff, and we do monitor this. We monitor the position of the tube in the patient's mouth, usually by the top lip. This one's measuring at about 22 at the top lip. Right? We also monitor the cuff that's at the end of this tube for an appropriate amount of pressure so that you're sealing the system so everything that's being delivered to the patient returns to the patient without escaping around it. Now, those are the three parts of the system: the patient with the endotracheal tube, the circuit itself, and the ventilator itself. But no discussion is complete about mechanical ventilation without mentioning what your backup ventilation device is. For those situations where you might not understand what might be wrong, but you know something's not right with the ventilator, meaning you might be hearing air escaping in the mouth, or perhaps maybe you're listening to breath sounds and not hearing something, and you're questioning this device and whether it's the purpose of its alarm. What you nearly need to do is you need to take the ventilator and connect up the bag to it and bag the patient until you page the respiratory staff to come and see exactly what's wrong with the patient. The simplest way to do this, count to three. 1, 2, 3, squeeze. 1, 2, 3, squeeze. 1, 2, 3, squeeze. Now, hopefully you'll be remembering at some point in time while you're doing this to connect this to the flow meter on the wall. Turn the flow meter all the way up as you're using this. There are a variety of ways for us to determine whether or not this tube is in place. One would be listening for bilateral breath sounds. There's another thing that we do not have here, but it's readily available. There'll be one in the bedside for this patient. It's called an end cap, for you to determine whether or not there's carbon dioxide coming up through here, which is our verification that the patient is adequately ventilated. All right, so for these endotracheal tubes, you will also see there's a Ballard suction in line. And there is an on-off switch for the Ballard suction, and when you lift it and rotate it, it shuts it off so it can't be inadvertently used. When it's not in use, you will see a little black line on that this is the proper position for it when it's not in use. You don't want to leave it down into the tube, into the patient, because it represents an obstruction to their ventilation. So when you were to use this suction, it's usually characteristically somewhere around 100 millimeters of mercury, you would turn the suction on, like so, and then insert this, as you would characteristically with suction, until you meet a restriction. Then as you withdraw it slightly, applying the suction intermittently while rotating the catheter as you pull it out. All right, then once you're finished with that, you turn this off. And this particular ventilator has a device to augment the oxygenation while you're suctioning, and if you should remember to do so, there's a 100% suction button here that goes on for 2 minutes period of time. So you would do that right before you would suction them. Do the suctioning, and then 2 minutes it will shut off, or pressing again will remove that 100% oxygen. It will go up from the concentration of oxygen that's being shown here on the screen to 100% for that 2 minutes period of time. All right, so that's your suction catheter, your endotracheal tube, and your circuit is a simple process. The circuit, it delivers a volume of gas, which comes from the wall, dry. So we have to provide some sort of means to be able to humidify the air that's being delivered from the mechanical ventilator. This is an HME, an artificial nose, that collects moisture on exhalation and then delivers that same amount of moisture to the patient on the next subsequent breath delivery. All right. On the exhalation side, well, there's a HEPA filter here for filtering out any particles, anything that might be remotely connected to what is going on in that patient's lungs, to protect it from being discharged into the room. All right, so the ventilator itself, characteristic, what you're looking at here on the screen, all right, this is a touch screen, but in the upper left-hand corner, what you'll see on this screen, it'll show you an adult image when this machine is set to deliver ventilation for adult patients, or you'll see a baby there. Since it's capable of performing ventilation of infants as well, you'll see a baby there. This one's set for the adult patient. The mode is displayed alongside of this. This machine is in PRVC, pressure regulated volume control. This is synonymous with probably the assist control ventilation mode that you've heard before. And anytime any mode expresses control in the mode, all the activity that's taking place here is all mechanical. The patient makes an effort, the machine responds to it and delivers, in this case, a preset volume. They're capable of delivering preset pressure, but what you'll be dealing with most of the time here is preset volumes for your adult patients. Right. This machine never locks the patient out of taking a spontaneous breath on their own. But if they're in controlled mechanical ventilation, as soon as they make an effort, the machine delivers the volume that's preset on this device. Now, this touch screen here, what you're looking at here is the graphic information. This is a characteristic pressure graph for PRVC. This is the flow graph here and the volume graph here, not something that you have to pay that much attention to. These are preset parameters that you can visually change and check things for. And alongside here, these are measured parameters. When you touch the mode here, the touch screen displays all the elements of the breath that's being delivered. It says here that PRVC, again, all mechanical activity. There's a sensitivity here, which we call a trigger. When this machine is triggered, you will see a little purple T on top here. Right, that machine is then recognizing that the patient's making a breathing effort, and it will deliver that volume in conjunction with the recognition of that effort. There's a rate control that's here. All right, now that will be based upon what the physician's determination of what adequate backup ventilation is, and 20 breaths per minute. That means every 3 seconds. It's designed to deliver a breath, all right, and it's giving you a guarantee of those at very least 20 breaths per minute for that period of time. But any breath that the patient takes, this machine recognizes it by triggering, and the breath is delivered according to what the volume is set here and what the oxygen concentration is set here. These other settings, this is the inspiratory time. This is how quickly the breath is delivered. The trigger, this is how much effort is taken for the machine to recognize the patient's breathing effort. All right, when you have this touch screen and you want to make changes, you can touch the parameter with this scroll knob here, dial in the number that you would like, and press it to acknowledge it and accept it by pressing the accept button. Normally what you'll see displayed here is the main screen. That's what you're looking at here. Again, touching this and looking what the basic parameters are changes nothing. But after you look, what you should be looking to do is pushing the main screen and putting it back to here, back to this display. All right, there are these visual displays that you see here. These are the analyzed parameters. On top here, what you see is the peak inspiratory pressure that's being generated. That's the total pressure that's taken to deliver the volume, this volume of 500 through this circuit system, through that endotracheal tube, and into the patient's lungs. You'll characteristically see this somewhere between 20 and 30. Right, the numbers that you see below this, the respiratory rate, that would be the total respiratory rate, the set machine volume, and how much the patient's taking. So if this is set to 20 and this is reading 30, that's saying that in addition to the 20 breaths, the patient is taking 10. Below that, what you'll see here is the oxygen concentration. Now, these two values should be the same or very close, within 1 or 2%. We're delivering 40% oxygen here, and you're analyzing 40% oxygen there. These numbers that are below here, this is minute volume, probably not something that should be very important for you to know, but it's the amount of volume that's moved in 1 minute's period of time. That's the rate and the volume totally. All right, the bottom here, there are two parameters here. Volume moved on inspiration and volume moved on exhalation. In real clinical situations, they should be fairly close to one another, those numbers. All right, we have alarm parameters here. We will be setting a certain volume to this alarm, and usually somewhere between 40% sound level and 100%. Depends upon how loud you want this thing to be. Basically, as far as any alarms go on the ventilator, this has a built-in low pressure alarm. So anytime that we're delivering a breath now, any part of that circuit becomes disconnected, what you're going to hear is you're going to hear an alarm go off. And that's pretty soft right now, but it's going to be a continuous alarm. The continuous alarm to tell you that something needs to be corrected. Usually intermittent alarms are usually related to something regarding the patient, right? And that usually is a high pressure alarm. And it's usually their reaction to the ventilator delivering a breath when they have secretions, and that they may need secretions cleared from their airway. That's your basic ventilation. Probably as simply as you say it, should say it. And I'm going to ask the audience that we have here, are there any questions, anything that we did not cover that you think should be covered?
Show them how to do the oxygen?
Adjust the oxygen parameters? That's a very good question. On the bottom of the servo here, the other way to adjust the parameters here are right here. There's 4 dials here. This dial here is to adjust the oxygen concentration. You don't have to accept anything. Whatever you dial in there is what the patient is receiving. The PEEP level, positive end expiratory pressure, that's a pressure that they'll be maintaining throughout the cycle of inspiration and exhalation that provides a oxygenation asset. And the rate control, you merely have to dial that in. And the volume control. Questions? Any other questions? Summer?
How will they know if the patient has an obstruction, like suctioning is needed? How will they know?
Usually you will see a high pressure alarm. It will register on top here. You will see a high pressure alarm, and the visual display of pressure here, you'll see it will be higher than it normally is. Usually we limit that pressure. On here it says 55. If the patient were either exhaling against the delivered breath or coughing in response to the delivered breath, it may register a lot of pressure. And it is an intermittent alarm, not a continuous alarm. You will see probably a response from the patient actively coughing in response to it, which means then you need to go to the patient, take your Ballard suction, prepare that by pushing the 100% suction button down here, and then turning and rotating this so that it's in a suction positioning, and then suction as I showed you before by putting the catheter all the way in, meeting the obstruction, and then withdrawing it slightly and rotating this as you're applying the suction intermittently. Another question?
Yes, when you press that 100% suction, aren't all your alarms silenced for 2 minutes? So you should make sure you stay attentive to the patient.
But usually you've taken care of that, yes. Probably during that period of time you wouldn't have to worry about alarms.
A pneumothorax.
Pneumothorax generally, an unusual circumstance, but possible for mechanical ventilation. That would be something that would be an alarming situation, very acute. You would recognize high pressures, usually a high heart rate. You will recognize an instability to the patient, which would then direct you to determining whether or not you're ventilating effectively. For all mechanically delivered breaths, for your checking it, there are bilateral auscultation of breath sounds, and that should be part of your key whether or not the patient may have a pneumothorax. Raised pressures, raised heart rates, an unstable look to your patient, and this would be for you to call your physician, for you then to contact X-ray, for them to make the determination based upon what you see clinically, whether or not there is a pneumo.
Perfect.
Thank you.
What about equipment failure?
Equipment failure. All right. If you've taken PALS or ACLS, you will be familiar with this DOPE mnemonic. This is to direct you exactly what could be wrong with this endotracheal tube. Now, I told you before, when we check the ventilator, we make sure that the mark of the tube, where it's supposed to be, and we monitor this every shift and throughout the shift, that the tube is marked at the top lip at a certain measurement. you will want to make sure, again, that your cuff is inflated properly. And you will clearly hear air up through that when it's not inflated properly. So these things don't disconnect, obstruction, pneumothorax, equipment failure. The disconnect would be the most important alarm in any ventilator is a disconnect alarm. And it's a continuous alarm. That ventilators, you may not hear it now, but it's a continuous alarm that's going on. That tells you that the ventilator is disconnected. All right, if you're not sure at that point what to do with that ventilator, and the respiratory therapist is somewhere else, that's why you have your backup ventilator, this manual resuscitator there. And it is not complete without its mask. Should that tube come out and you have to respond to that, you need this bag, and this mask together. They're not complete without both of them. So, should you have an alarm and it's continuous, well, you would take your bag and you would then provide support with this patient and hopefully remember to connect the oxygen up to the wall, turn the flow meter on, and then 1, 2, 3, squeeze. 1, 2, 3, squeeze. All right, and then what you're going to do then is hopefully somebody's going to come along and look to see, well, is something become disconnected? Or is something wrong with your endotracheal tube? So is there a disconnect? Is there an obstruction? Well, that could be from mucus obstructing it.
A kink.
That usually is something that creates a high pressure alarm, or possibly, if this is an oral endotracheal tube, the patient may possibly bite on this tube. Now we usually put tube holders in when the patient has upper and lower tube teeth to prevent them from biting that, but that is another way that this could become obstructed. Kinking, probably not something that would normally happen. We only keep a certain amount of length of tube outside of the patient's mouth. So obstruction would probably be related to mucus, or perhaps maybe the patient. The pneumothorax, again, that would be an emergent situation. This is an acute situation that doesn't happen very often, but it is possible when you're delivering positive pressure breaths to a patient for them to develop a pneumothorax. In which case you would revert to listening to bilateral breath sounds. Are you assured of good sound? Which is how you confirm appropriate ventilation to begin with. Something that you probably should get used to do when you go in to see your patient. Listen to a breath sound here, listen to a breath sound here. And at least have some reference for yourself. Pneumothorax, that takes care of the pneumothorax. Equipment failure, if there is no reason, if there is nothing here that can be solved, your respiratory therapist will have to replace this device. Could be something related to the circuit, which is much more common. Could be the alarms that you're having are related more to the patient. Could be they need to be suctioned. Right? And sometimes it's a matter of the patient becoming more aware of what's going on around them. There's usually a balance that you're creating between how much sedation you're giving an individual so that you can provide support for them, while at the same time allowing them to take a spontaneous breath. On this ventilator, recognition of a spontaneous breath, though you don't see here, is a little purple T that will show up on the screen. That says that the machine is recognizing a breathing effort that the patient is making and shows you that it's triggering the machine.
Last, can we show them how to connect the bag to the ET tube?
Okay.
In case they've never done that before.
Hold on a moment, student, and we will get to you. All right, so you have a patient that you might feel something's wrong with the ventilator here. So this is, again, your backup ventilator. We're going to take this, and there's a filter here to provide at least control of anything that patient's exhaling. All right, you will be connecting that to the endotracheal tube. Now, there are, for each intubation box, each airway card, each code card, there will be an end cap on there. There will be one in the room with this patient, usually. For you to put it on to determine, I'm going to put this on the device on there.
No.
For you to determine whether or not, is there an end cap in there? Okay. This is the package that the end cap comes in. And it detects air that has higher levels of carbon dioxide in it. The normal levels of carbon dioxide in the air are trace elements. It won't change the color of it. There's water here somewhere. Pardon me, I have to get a drink.
Hydration, very important.
Okay, so I'm going to open this up. Don't tell anyone.
We won't.
There should be someone. It's an easy open package that won't open up.
Probably an old one.
It's like litmus in response. Okay, in response to a breath that contains enough carbon dioxide on it, you will see a sort of a beige change in the color of this, beige to yellow. That signifies that you're recognizing an exhale breath that has carbon dioxide in it. Otherwise, excuse me, the breath will remain, the color of this will remain purple. All right, that would be a question of a thing. If you were to take this and connect this up, and you were bagging the patient, and it were to remain purple, that would be something for you to question not whether this tube is in its proper place. And the immediate sequence then is once you put that in, listen to your bilateral breath sounds. Now, if that tube should happen to come out, well, you're obviously going to be calling for help before then. That's why you need the mask. And if there's some doubt about whether this is out here, what will happen is if you're not adequately exchanging air, we will pull this tube out and ventilate, bag, and mask, such as this. Usually requires a tonsil suction in the room as well for any oral secretions that appear there. And again, that would be your respiratory therapist or anesthesia being paid to replace this endotracheal tube. So that's how you would use that. This is how you would use the end-tidal CO2 to verify the determination of whether or not this tube is actually in the patient's lungs. Would only be beige or yellow if the patient's tube is in the trachea.
Okay.
Okay, so questions
Your
anymore?
question?
Yes, young lady?
What if one of those little things pops off?
What are these little things?
Yeah, what happens?
Well, you'll
to the
certainly hear
ventilator?
air escaping, and what you'll probably get is you'll probably get an alarm.
Okay.
But what will also happen here is because in the delivery system, and this would be a line that we would connect with certain devices to monitor the pressures here. There should be a cap on this. If this were open, what would happen is, as this machine is set to deliver a certain volume, a lot of it is escaping through this opening. So what could happen at that point, it could be an alarm will go off to tell you certain part is being disconnected. And you could also recognize as you look at the ventilator, the delivered volume, which in this case is now set for 450, as you're delivering it on inspiration, it may say 450, but on the exhalation side that we'll see monitored here, it might be much less than that. And you'll want to correct that by making sure that the cuff is sealed on the tube, everything in the circuit is connected properly, and all the air that the machine is delivering to the ventilator is being delivered to the patient.
Thank you.
Questions?
No.
Nope.
Okay, good
Excellent.
luck. There's a problem with this ventilator. That's what your backup ventilator is. The bag is there for
Oh, respiratory stat.
respiratory stat, and we'll come and we'll assist you in this problem.
Thank you.
Good luck to you.